Good afternoon, everyone. I'd like to thank Paul and Kevin for inviting me to be part of today's faculty. Paul's been quite a mentor for me for she's almost 2 decades now. My only regret about today is that I can't be in Cape Breton in person. Uh, I'd love to have an excuse to go to Cape Breton and perhaps squeeze in a couple of rounds of golf. I'm actually supposed to be at Cabot Links next weekend. So, Paul, if you need someone to look after your chalet there, you have my email address. Anyway, on to the talk. I've been asked to speak about basically the care of the chronic coronary patient. And the title of the talk is long. I didn't choose it, but I'm very happy to speak about it. It's monitoring and management of post-MI patients. What drugs can be stopped or changed in the first year versus which treatments are disease modifying and should be prescribed for life. A very pertinent talk. Coronary disease is so common. We all see these patients essentially daily. I had a patient in clinic just yesterday. I had a infralateral ST elevation MI earlier this year, treated in Halifax. It's the first time I met him, and the first thing he says to me is, "Doc, what drugs can I stop? Or are there some of them that I need to be on lifelong?" And I felt like grabbing my laptop and showing him my slides, but I didn't do that. I resisted that temptation. So just a brief overview of what I'd like to cover today. It's a big topic, and you can imagine there's lots of drugs to talk about. And in cardiology, we're so blessed to have so much evidence. I could show dozens of slides with data and whatnot, but I think ultimately I'm just going to focus on what I do pretty much for the clinical care of these patients. I'm going to talk just briefly about the post-MI patient and some considerations we have to make when looking at their characteristics. And then kind of the actual medications that I want to talk about, there's 4 or 5 classes: antiplatelets, lipid lowering agents, beta blockers, ACE inhibitors, and ARBs. These are the usual suspects in the care of these patients. In terms of emerging therapies, Dr. Raymer's already given a talk on colchicine, so I'm not going to touch on that at all. I will talk briefly about low-dose rivaroxaban for the treatment of for patients with known coronary disease. So the post-MI patient, they're not all the same, obviously, and there's lots of variation in how they present. There's lots of questions to ask. Now, a lot of these questions really are important to, in terms of their treatment in the first year. However, beyond 1 year, to some degree, these questions may not be as pertinent. But things I want to know are, was it a STEMI or a non-STEMI? Was the patient revascularized? And if so, was it with a stent through PCI or percutaneous coronary intervention? Or was it with bypass surgery? Probably the most important factor that I want to know, both short-term and long-term, is what's the patient's ejection fraction? Do they have significant wall motion abnormalities? And of course, there are other special circumstances. Do they have a history of atrial fibrillation, peripheral arterial disease, diabetes, renal failure, prior vascular events? And it may sound obvious, but ultimately our goal, generally in the first year, is to reduce the risk of complications from the MI itself. And then sort of beyond that, in the years down the road, we want to reduce the likelihood of a recurrent event. Now, more and more our practices are guideline driven. The Canadian Cardiovascular Society has a fantastic set of guidelines available on their website. There's an app as well. Interestingly, there's no recent MI guideline, or really no guideline specifically dedicated to the care of the post-MI patient. They have excellent and new heart failure guidelines and new dyslipidemia guidelines just released in March. And then I also looked at the 2018 antiplatelet guidelines for some of the slides for today. But if you're looking for specific MI guidelines, you can look towards the US with their AHA ACC guidelines, or to the European Society of Cardiology guidelines. So getting onto the meds themselves, in terms of antiplatelets, I think it's without debate that low-dose aspirin should be used lifelong in all patients who have no contraindication. I didn't put on the slide here, but Plavix or clopidogrel at 75 milligrams daily would also be an option if they're unable to take aspirin. In terms of dual antiplatelet therapy, now we've been using this now for most of my career, going back to the early 2000s. And it's generally, we've been using dual antiplatelet therapy, or DAPT, in all MIs for generally 1 year. That's sort of been like the magical time frame that we use. And most commonly, we use aspirin plus clopidogrel or Plavix. Less commonly, but probably increasing in use, is aspirin plus ticagrelor or Brilinta in PCI patients. There was a trial called the Plato trial that compared ticagrelor to clopidogrel in patients after PCI, or patients after MI undergoing PCI, and there was a 1% absolute reduction in death. So there is some significant benefit in ticagrelor, but the cost is increased risk of bleeding. So it's been a little slow to catch on, but we're seeing increasing use of it. But essentially, it's basically Plavix or ticagrelor for 1 year in addition to the aspirin, at which point you can go to aspirin alone. Now, the Canadian guidelines, the 2018 antiplatelet guidelines, actually recommend considering going beyond 1 year of dual antiplatelet therapy in patients undergoing PCI. And this is straight out of the guideline document. If you just follow the algorithm, basically a PCI for STEMI or non-STEMI, there's aspirin plus ticagrelor, or prasugrel, which is another antiplatelet that we don't really use much in Nova Scotia. So basically, it's ticagrelor or clopidogrel or Plavix, and they all get it for 1 year. So at 1 year, you're supposed to determine the bleeding risk. If they're high risk of bleeding, you go back to single antiplatelet agent, which, as I mentioned, is aspirin or clopidogrel. If they are not at high risk of bleeding, then the recommendation is to consider dual antiplatelet therapy up to 2 further years. And it would either be a lower dose of ticagrelor or continued Plavix at 75 milligrams daily. A trial looking at ticagrelor in this patient population. So these are patients who do not have a traditional indication for dual antiplatelet therapy. They were continued on aspirin, and they were either given placebo or 1 of 2 doses of ticagrelor. And what the finding was that there was a significant reduction in combined cardiac events. It's primarily driven by a reduction in recurrent MI, although there was an almost significant reduction in cardiovascular death. And like most trials where you have less thrombotic events, you have increased bleeding. And sure enough, you saw that here. At the usual 90 milligram dose, you can see the bleeding risk here compared to placebo. At the lower 60 milligrams twice daily dose, you can see what the hazard ratios are here. There is an increased risk of bleeding, but with the potential benefit of reduced MI and possibly reduction in cardiovascular death, because it looks like the bleeding is a little lower in the 60 milligram dosing as opposed to the 90. The 60 milligram dose would be the one you would switch to after 1 year to be continued on for about 2 further years. In clinical practice, if you look at the guideline, it actually suggests that it would maybe be something you'd be doing in most patients, because most patients are probably low risk for bleeding. But in reality, this is really done in a select population. And it's almost the default seems to be 1 year, unless they have a high risk of recurrent event and a low bleeding risk. So it's not just enough to have a low bleeding risk, but you probably have to have some markers for increased risk of a recurrent event. And I think that this decision, I wouldn't expect this decision to be in the hands of primary care. I think that it should either come from the cardiologist and follow up, or even from the hospitalization, like from the interventional team that puts the stent in, to give us an idea of what, if they have any concerns about recurrent thrombosis. And so things I think of are, have they had is this their third MI in the last 5 years kind of thing? Is the PCI a bifurcation lesion? Is there a lot of stents? Is there a long stent? Was a left main involved? Those kinds of things are what I look at. And of course, coverage is always an issue. Dual antiplatelet therapy beyond years not covered by Pharmacare Nova Scotia. It would be covered by primary insurance plans, however. So beyond antiplatelets, there is another option in reducing recurrent events in patients with known coronary disease. Low-dose rivaroxaban was looked at in this population in the COMPASS trial. These were patients who were basically just patients you would have on aspirin daily, and they were randomized to placebo or to 1 of 2 doses of rivaroxaban. I'm just going to talk about the 2.5 BID dosing now. But basically, these patients who ended up on rivaroxaban had a significant reduction in recurrent events. There was a major reduction in limb ischemia, strokes, a not quite statistical significant decrease in MI, interestingly, but there was actually a reduction in all-cause death. And so if you look here at the hazard ratio for combined events, it looks like those patients with CAD and PAD actually had the biggest benefit. And again, like I said, anytime you reduce thrombotic events, you almost always increase risk of bleeding, and that was no different in this study. But the net clinical benefit was there in favor of adding low-dose rivaroxaban to aspirin. And the benefit is most pronounced in patients who have both CAD and PAD. And in fact, this dose in this patient population is actually covered by pharmacare. And that's relatively new. I think it was late December or early January when coverage was approved. So that's an option as well. In terms of lipid lowering therapies, again, like aspirin, I think it goes without debate that a statin is indicated lifelong for secondary prevention in coronary events or any vascular event. The lipid guidelines were updated in March of this year, and they've changed a little bit. They now consider coronary disease a so-called statin indicated condition, and they kind of say that there really is no goal anymore. But when you read through it, really the goal is, I put 1.8 here, it's actually more like 1.7. Kind of what they say is that if the secondary prevention patients have an LDL greater than or equal to 1.8, then you should intensify therapy. And the intensification is either with ezetimibe or Isotrol or a PCSK9 inhibitor if they're in that category. This is the actual guideline slide here. Just ignore this here. This is what Nick talked about earlier today. So patients who have known vascular disease, basically, if their LDL is greater than or equal to 1.8, you should intensify therapy. If they're kind of close to target, they recommend Isotrol plus minus a PCSK9 inhibitor. If they're further away from target, then they would suggest going with a PCSK9 inhibitor and Isotrol. Realistically, LDL, I think, is still the most popular target that we're using. You can use ApoB if you have access to that, or you can use non-HDL-C if you wish. Now, so I think lipid lowering is pretty straightforward. Now beta blockers and ACE inhibitors, which I'm going to talk about next, are probably the more controversial therapies. The data for beta blockers stems primarily from before the reperfusion era. So this is data from the 90s and early 2000s, before we started cathing everybody and revascularizing as aggressively as we do now. And the biggest benefit is seen in those with ejection fractions less than 40%. And that kind of actually comes more from the heart failure data. And so I think it's without question that patients who have an ejection fraction less than 40%, they should be on a beta blocker long term. And even if the ejection fraction does rise above 40% or normalize, they should remain on it, as there's good evidence that stopping beta blockers and ACE inhibitors in recovered LV dysfunction is associated with a high rate of relapse. Now, the question is, well, what's the benefit of beta blockers in patients who have an ejection fraction greater than 40%? Well, it's actually not well defined. There's very little randomized prospective data looking at this patient population. And then there is registry data looking at this, and it's conflicting. This is from Kaiser Permanente data from California. And what this shows is that patients who have a prior MI and are on beta blockers seem to have a reduction in death or MI. However, in the REACH registry of thousands of patients around the world, in patients with a known prior MI, there was a trend towards benefit, but despite thousands of patients for many years, there was actually no clear benefit in this population. So in those with an ejection fraction greater than 40%, it's not well defined. The American and European guidelines consider the use of a long-term beta blocker in these patients to be a class 2 indication, which basically means that it may be beneficial and is not harmful. And there's really no guidance as to how long to treat the patients. Most of the studies only went for a few years, but the statin studies only went 3 to 5 years as well, and we don't stop the therapies at 5 years, because that's how long the study went. So, in my mind, if you're committed to a beta blocker, there's no reason to stop it unless something comes up. But of course, aside from the coronary disease, you got to ask yourself, are there other reasons why they should be on a beta blocker? Do they have a history of tachycardia for whatever reason? Do they have migraines or tremor? ACE inhibitors and ARBs, the data and their use is actually very similar to beta blockers. I think it's quite clear and without debate that they are indicated long-term for patients with ejection fraction less than 40%. ACE inhibitors are to be used in preference to ARBs, but if they develop cough or whatever reason, they can be switched over to an ARB. I think that, and again, they should not be stopped, even if the ejection fraction does go above 40%. And again, like beta blockers, their benefit in patients with ejection fractions greater than 40% is unknown and questionable. Back in around 2000, there was a big trial called the HOPE trial published looking at patients with stable coronary disease or high risk for coronary disease. They had to have a normal ejection fraction. And famously, Salem Youssef, who was the lead author out of Hamilton, presented this data, and there was a major reduction in all-cause mortality and combined events. And so that really changed the use of ACE inhibitors in patients with coronary disease. However, over the next decade, multiple studies came out looking at the same population, and this was the PEACE trial published in 2014. I apologize, the reference didn't come up here, but it was PEACE trial. Eugene Braunwald was the lead author, and again looked at patients with stable coronary disease and normal ejection fraction. And I was actually at the conference when this was presented, and there was almost like a gasp when the two lines were basically superimposed, and there was really no benefit of ACE inhibitor in addition to standard medical therapy. And the belief was that between the time that HOPE got published and PEACE got published, was that in that time frame we started to revascularize more aggressively and use statin therapy a lot more aggressively as well, so that the benefit of the ACE inhibitor basically kind of went away. So this data has led to ACE inhibitors and ARBs also receiving a class 2 indication for patients with an ejection fraction of greater than 40%. And so, but again, there may be other reasons to keep the patient on these. These are excellent antihypertensives, and they play a very important role in terms of diabetic renal disease. So it kind of comes down to, what do I actually do in my own clinical practice? It's kind of like the summary. So when I see a post-MI patient, basically they all get dual antiplatelet for 1 year, unless of course they have bleeding or some emergency surgery come up in that time frame. And I hope in my notes I'm clear and say, well, they don't need the ticagrelor or the Plavix beyond 1 year. And then at that point, you just put them back to aspirin alone. Now, of course, if they've had repeat events or have a high risk, stent or procedure, I may consider 2 further years of dual antiplatelet therapy. Not common. I would estimate it's less than 20% of my patients. If they have, if they're going back to aspirin alone and they have known PAD and they have coverage through Pharmacare or private drug plan or competitive pocket, I would talk to them about rivaroxaban 2.5 milligrams twice daily. Again, a statin for life. I think that's without debate. Again, their target is essentially 1.8 or I guess 1.7. If it's above 1.8, I'd add Ezetrol. Basically, I just go to max statin and then add Ezetrol. And if they remain significantly above 1.8, I would consider a PCSK9 inhibitor. Well, the question is, well, what's significantly above 1.8? There's a lot of factors in that, what the patient's preferences are. If they're 2.0, I don't know if it's worth it to spend that money for all these years to get them down below 1.8. I might be wrong that the right thing to do is to put everybody on a PCSK9 inhibitor, but I don't think the data quite supports that just yet, especially at their current cost. If they're above 3, I think it's a no-brainer that really you should try to go after their LDL and add in a PCSK9 inhibitor if you can. And then if their EF is less than 40%, well, they need treatment as per the, the heart failure with reduced ejection fraction guidelines. So they need a beta blocker, an ACE, or an ARB, or one of our neprilysin inhibitors, such as Entresto. They may need an SGLT2 inhibitor, and maybe an MRA like spironolactone. So that's a whole really a different kettle of fish. But in terms of beta blocker ACE inhibitors, they would absolutely be indicated in those patients. Now, well, I guess the question is, well, what if their ejection fraction is greater than 40%? What do I do for those patients? If they're on an ACE and beta blocker and they're tolerating it, I generally don't entertain stopping it. However, if they come to me or if the family doctor, if someone asks if they can stop it, I like to know why they want to stop it, and then I kind of look at what their situation is. If they have truly normal ejection fraction and it was never low, there's no significant wall motion abnormalities, they've been fully revascularized, the blood pressure is at target, then yeah, I mean, there's probably not much harm in stopping these medications. How long would I insist that they stay on it? Well, I mean, there's no guidance on that. I'd probably say stay on it for a year or two. If I had any concerns, you can always recheck their ejection fraction down the road before making a decision. Sometimes too, that if they think they have a side effect from it, I kind of say, look, let's stay on it for 6 months to a year and see how you do. The side effect kind of goes away, and then you're kind of left with no need to make a decision. That patient I saw yesterday, he did not have hypertension. He wasn't quite fully revascularized. He had some disease in a small RCA. And in the end, I talked to him about their potential benefit. I said, they're not going to hurt you. And in the end, actually, he said, you know what, if they may help me, he goes, I don't want to risk anything. So he'd end up staying on them. But if he said, you know what, absolutely not, I don't think I would have fought too hard. If he even wanted to stop his aspirin or a statin, it'd be a different situation. Anyway, I'm just about a minute over time here, so I apologize. But I'm going to finish up with that. Actually, I think I have one more slide. I just couldn't resist. Anyway, thanks so much for listening today.